I want to talk a little bit through volume assessment and responsiveness, especially because it's such a big part of critical care and care provided by our emergency medicine colleagues and more so by our hospital medicine colleagues as well. So it is a topic that covers a lot and is very important for direct patient care. And I've titled the talk as IVC size and collapsibility are not enough. And it's because primarily like IVC views are relatively easy to get, and the and and all of our colleagues who start in the beginning find it very exciting and encouraging to get the IVC views and make huge treatment decisions based on that. But the more and more we've reviewed the data, the more we know that the size and collapsibility of IVC is a pursuit that has not really panned out well in as being the only measures that can help with this assessment. So let's dive a little bit into this topic. So what I'm trying to go through today is to actually define what these two terms mean. I've seen them and I've personally used them interchangeably, but I think it's very important to differentiate what these two terms are. Understand why just clinical assessment alone is insufficient in this assessment, discuss the most common methods of volume assessment and responsiveness, and go through some of the pitfalls and examples while we're doing it. So in the beginning, when I started thinking about this, I was always a little bit like confused and wondering to myself what the two terms are. And as I dived a little bit deeper to try and define it well, I think I found some clarity for myself, and that has led to a lot of clarity for the trainees that I go through these topics with. So volume assessment, it's not the same thing as volume responsiveness. It's basically an assessment of patients' intravascular and extravascular fluid status. A lot of times, the way that I've heard and seen this question being phrased is, if needed, can the patient safely tolerate fluid administration? If I give this fluid, will it adversely affect them, with or without thinking about whether it's going to make a change in their cardiac output? And further going on to say that it does not predict if giving fluid or a fluid bolus will lead to an increase in cardiac output, which generally is the more interesting question for most of us in critical care as we manage patients with shock. Volume responsiveness, on the other hand, is the increase in left ventricular stroke volume in response to fluid administration. How is it defined? There is a little bit of variation in the literature on how people have approached it. So a 10 to 15% increase in stroke volume upon giving 10 to 20 ml per kilo of fluid bolus is generally considered volume responsiveness. And this is the concept that helps differentiate some of our patients who may be volume replete and yet can still be volume responsive. So think about that for a second as we move on to the next slide. So generally, when I think about assessing the fluid status, it is helpful for me to think about what were all the things that we were doing before using POCUS or echocardiographic assessment, and then all of the things that we have started doing since then. As a general key, each of these different methods is denoted by whether it's a static method or whether it's a dynamic method, and you're able to get information real time, constantly changing. And so think about that. So the non-POCUS methods are, you can use your clinical exam. So what are certain things that help with that? These are pretty obvious to all of us in critical care. We look at the heart rate, we look at the blood pressure, generally the systolic blood pressure, and then the systolic blood pressure variation and changes with those upon giving a fluid bolus. So, hey, my patient in shock is tachycardic. I gave them some fluid. Their heart rate came down by several points. Maybe that indicates fluid responsiveness. Hey, my patient's blood pressure was low. Now it's improved after giving fluid bolus. Probably indicates fluid responsiveness. Absolutely it does. The hard part is when the heart rate and blood pressure are high or low for other reasons, not just fluid administration issues, and you need additional data to sort out whether a patient is fluid responsive or not. There are several invasive methods as well, which they've been used on and off. Some centers prefer them more over the others, but none of them have found to conclusively be helpful. So the most common one amongst them is obviously our CVP monitoring, usually through a line that's in the neck vessels or in your subclavian, that can be tied to pressure transducer, and you can get a sense of what the right atrial pressure is. There is the pulmonary artery occlusion pressure, systolic pressure variation, and pulse pressure variations as well, which are used as other methods. And let's look through a little bit of these and what the evidence around them is. So the first thing is, why is clinical exam not good enough? Or why is clinical exam not sufficient to be able to determine volume assessment? So this was a study that was done back in 2003. The question asked by the study was a pretty simple one. How accurate is a physician's estimate of cardiac index and volume status? The study was designed keeping in mind comparison between clinical assessment versus a transesophageal echocardiogram versus a PA catheter. And what the study found is that both in terms of assessment of cardiac output, as well as in volume status of the patient, the physicians were able to predict it correctly only about 30 to 35% of the times. And the rest of the times, either it was an over and or underestimation of the true value. So if we think about it, this is worse than even what a coin toss would show that the patient has normal cardiac output or decreased or whatnot. As an aside in this study did show that transesophageal echo interpretation of cardiac output and volume status were pretty comparable to what the PA catheter shows. And I think is one of the earlier studies that helps support the use of echo to make these judgments and decisions. So there were two conclusions that I personally took away from this study. Number one was physical exam alone is insufficient for assessment of volume status. And number two is transesophageal Doppler measurements are comparable to PA catheter data, at least for the assessment of cardiac output, which was also the conclusion from the authors. Because there has been such a massive interest in this question, we can all assume that this question and all of the different metrics have been looked at over and over and over again. And so from those have come several different systematic reviews and meta-analysis that have looked at the predictive value of each one of these. This first review was done back in 2008 in CHEST, and subsequently other studies have looked at it too. But it looked at the use of CVP data to make clinical decisions regarding fluid status and found that CVP was generally not very good. The ROC was only about 0.56 in 24 studies. And the positive predictive value of CVP was also not robust enough in these studies. Subsequently, there has been a newer systematic review and meta-analysis on this subject. This was done, I think, back in 2020. It included all adult patients, and a total of 20 studies were included in this, where they used Cavel indexes. So if we look at this ROC curve right here, we see that the ROC is around 0.7, which is not good, which is average. But the other big issue with the study is that all of these different studies were quite scattered. And generally, when you see that on this AU-ROC curve, to me, it means that there was a really wide confidence interval, which you can also see in the confidence interval that's listed in the text here. So anywhere from 0.46 to 0.83, which doesn't make this data very usable, very reliable, and speaks to me that using inferior vena cava data, which is a reflection of in some ways of your CVP data, is not very good. There have been other meta-analysis, for example, this one that was done back in 2013, which looked at multiple different static measures and found that these static measures had, again, a pretty low AU-ROC for prediction of patients' volume status accurately. The only one that was actually found to be somewhat useful was the stroke volume index, which we will talk about in the more dynamic ways of assessing information. So these were some of the non-POCUS ways of looking at the question of volume status. But let's think through what are some ways that we can use POCUS to study volume status and how they are helpful. And generally, again, I try to break them down into the static measurements and the dynamic measurements. The static measurements are somewhat that a lot of people early enough in their use of POCUS are quite familiar with, which includes IVC diameter, IVC to aorta ratio, left ventricular end diastolic area and volume, and then dynamic measurements, which includes your Cavel indexes, which is collapsibility, distensibility index, and your AFV index, or aortic flow variability index, which is going to be the most important and the most predictive method for volume assessment. So for left ventricular end diastolic area and volume, generally we try to get views of the LV either in parasternal long or in parasternal short axis. In apical, four-chamber view is also a really nice view to get a nice assessment of the end diastolic area and volume, and then you obtain a trace of these diameters, which could be used to predict either the area, or if you have more than views in more than one planes, then the volume. The great part about this assessment is it's easy to do. It's quite reproducible. It's better than just the clinical exam by itself. It probably adds some value to your assessment, but it was found to be poor predictive of volume responsiveness in adults. And there are almost no studies, at least to my knowledge, in pediatrics that have looked at this value. And largely, I've really never used this in my practice for volume assessment or responsiveness. IVC diameter. This is one of the original studies from where the use of IVC diameter for assessment and volume responsiveness came about. This was a study that was done in trauma patients that came to the trauma bay, more or less exclusively with hemorrhagic hypovolemic type of shock. And in those adult patients, what they found were when the size of the IVC, based on what the size of IVC was and the change in inspiration, it correlated to a right atrial pressure between 0 to greater than 20 when monitored with a central venous line. And so this data has been extrapolated into both adult and pediatric settings. However, in patients where the reason for hypotension or shock is anything but hypovolemia, this doesn't really pan out well. The other issue in case of pediatric patients is that the size of the IVC changes with size. And so really it's hard to use this data and extrapolate it into pediatrics. Nonetheless, the way I think about using just the IVC diameter is that it is almost not useful for volume responsiveness, but it may give me an idea about the patient's volume status. The way that IVC diameter is looked at is you use a low frequency cardiac probe. And if that is not available, an abdominal or a curvilinear probe is just as fine. The probe is placed in the subxiphoid area, and the probe marker with a cardiac probe is either towards the patient's head or towards the patient's feet. Either one would be fine. And the only thing that it changes is the way that your picture will appear on the screen. And we're going to look at those differences in the next slide. And then the measurement for IVC is made about 2 centimeters behind the entrance of the hepatic vein. So let's look at a couple of cartoons. So in abdominal preset, if your probe marker is towards the patient's head, then generally the right atrium is on the left of the screen, and the IVC is seen entering into the right atrium from the right of the screen. And sometimes you can see the hepatic vein, and other times when the patient is really dry, dehydrated, the hepatic vein may be completely collapsed. And then in the cardiac preset, that image is flipped. I have a couple of examples of what IVC assessment looks like. So for orientation purposes here, we can see the right atrium, liver, and the IVC along with partial view of the hepatic vein draining into the right atrium. And in this patient, in this view, there seems to be a significant amount of change in the diameter of IVC. Even though it seems what people would describe full, there is almost complete collapsibility of the IVC here. So having reviewed like where this data or where this intent of using IVC diameter came about, looking at some of the pictures, understanding a little bit, I want to explore some more into why IVC diameter in pediatrics is not useful. I think the first thing that we have to think about is that it relies on the concept of using CVP as an accurate measurement of fluid status or responsiveness. But we've already seen from the previous meta-analysis from CHEST in 2008 that that actually isn't good. So we're using a flawed and not accurate measurement, and then we're using a surrogate of that. So it's quite unlikely in my mind that that would work. As I mentioned, IVC diameter changes with age and weight of the patient. So what we don't really know what those normative values for pediatrics are versus what the adult data shows. IVC diameter is prone to changes with positive pressure ventilation, if the patient has abdominal hypertension, if there are changes in vascular tone issues. So how do you factor all of those things into just a single static measurement? You can't. And then in spontaneously breathing patient, that's where I think there is a little bit of value of just IVC diameter alone.
Into computer audio.
If those patients have either pure hypo or hypervolemia, And in those cases, extreme of measurements like a IVC that is negligible in size, completely collapsed, versus an IVC that is pretty large in size, I think I can make some judgment about the former being fluid down, dehydrated, hypovolemic, versus the other one being hypervolemic or fluid overloaded. And actually, Dr. Basu's study that was published, I think, 2 or 3 years back, showed that IVC values could be a useful predictor for patients' fluid overload status rather than fluid responsiveness. A, a comparable way of looking at the static measurement was the use of IVC and aorta ratio. And this was pioneered by our nephrology colleagues, where they used this comparative ratio to look at the patients that came to the hospital with these few different diagnoses of renal injury. And they obtained the value of IVC aorta ratio at presentation and then at discharge to predict their fluid status. And I'll come back to this slide in a second. And what they found is that in patients who had intravascular, who were either intravascularly depleted or fluid overloaded, they could predict with a fair amount of accuracy an IVC aorta ratio less than 0.8 would be predictive of being fluid depleted. An IVC aorta ratio greater than 1.2 could be a predictor of fluid overload. And in between 0.8 to 1.2 was indeterminate status based on just using that ratio alone. And so again, I think there is some value in these extremes of data in patients with just pure volume issues or hypovolemia or hemorrhagic shock. But outside of that, again, I think for all the reasons we talked about, similar to IVC ratio, IVC diameter alone, this doesn't really work. However, when I do have to do the IVC aorta ratio, I prefer to do it in the transverse or the short axis. And so the probe is turned at a 90-degree from the long axis of IVC, and then the IVC and aorta diameters are compared side to side, and those can be, the maximum diameters of both are measured and compared to obtain this ratio. So my final sort of takeaway from the IVC aorta ratio is it's useful in volumetric assessment, does nothing for me for volume responsiveness. It could be helpful when you use it along with all of the other clinical data and some of the other tools we've talked about, but as a standalone tool, probably not good to use it. For IVC aorta ratio, the AUC from meta-analysis was 0.78 with a reasonable sensitivity. So it could work. You can use it, just be very selective in which patients you're going to use it for. Okay, we talked a lot about these different elements of volume responsiveness, which has brought us to this point of dynamic measurements of volume responsiveness, which really is where the field has moved on and which are really helpful. So there are really two big determinants using dynamic approach. One is the Cable indexes, which look at collapsibility and distensibility. And then there is aortic flow variability. So let's look into that a little bit more. So I think we have to talk a little bit about what happens when the patient is on positive pressure ventilation, what are its effects on right atrial pressure. And so as we can see here, that with a positive pressure breath, there is an increase in the intrathoracic pressure within the chest. In terms of our CVP, this leads to a increase in central venous pressure, and hence your CVP rises. Positive pressure tends to push out some of this venous blood out of the chest cavity. your venous return is decreased as your right atrial pressure goes up. And then again, similarly here, your RV preload is going down, your RV afterload is going up. And so there is decrease in the overall amount of RV stroke volume. Another way of looking at that is this curve, which compares right atrial pressure to your cardiac output and to your venous return. And so here we can see that as the right atrial pressure decreases, the venous return and subsequently your cardiac output goes up. The converse of that is as your right atrial pressure goes up, your venous return is starting to come down. So a lot of the dynamic measures are based on this understanding of physiology. And so the first one that investigators have looked at to the point of exhaustion is IVC collapsibility index. So in spontaneously breathing patients, as we said, intrathoracic pressure drops with inspiration, IVC empties into the right atrium, leading to collapse. And so the collapsibility index can be calculated as the maximum IVC diameter minus the minimum over the maximum times 100. And studies have found that in spontaneously breathing patients, a collapsibility index greater than 50% indicates volume responsiveness. When it's less than 50%, it could be because the RA pressure is elevated for one reason or another and may not be related to fluid status alone, and so is not a helpful measure in predicting volume responsiveness in these patients. I think there is some value to using IVC collapsibility index and extremes of values. So greater than 50% for me is an extreme of value in deciding if I should give this patient some fluid and is it likely to cause an increase in their cardiac output. This is an example of a patient's IVC where the collapsibility is more than 50%. So here I can just even visually look at it. I don't even have to do all these measurements to figure out that the collapsibility is probably more than 50%. Here's another example where the IVC looks what is described sometimes as plump and full, and there is pretty minimal variation in the size of the IVC. And so I think this wouldn't fall into the bucket of IVC collapsibility more than 50% for me. The more accurate way of doing this is using the M mode. So the M mode line is placed about 1 centimeter to 2 centimeters behind the hepatic vein, and then the M mode tracing is obtained during the patient's respiratory status. And as we can see, this is a pretty helpful both visual aid as well as a helpful aid if you have to measure the actual diameters. And in this example, shows almost complete collapsibility of the IVC. One of the big pitfalls that you have to remember if you're doing this is that your IVC moves slightly up and down as the patient breathes. And so sometimes the change in IVC diameter may actually just be that your IVC is not in the plane of your measurement and has either moved up or down. And so in those cases, I actually have now started using IVC diameter measurements in transverse plane, like we did for IVC aorta ratio. And in that case, you're able to see if the IVC is moving in and out of the plane with respiration versus there is an actual true change in the size of IVC with respiration. This is an example of an IVC in M mode, which doesn't change very much. And so essentially we can take different measurements, but essentially there's no change in diameter, so very minimal collapsibility. The converse of IVC collapsibility index is the distensibility index, which is what follows our previous discussion about the physiology of a positive pressure breath and the fact that there may be changes in the size of IVC and it actually goes up in size versus collapsing. And so distensibility index is calculated as your IVC. There are actually two different formula. One uses IVC max size, IVC minimum size over minimum size times 100. And the other one uses the mean of the maximum and minimum size of IVC diameter. And based on which formula you use, the number that predicts fluid responsiveness is either 18% or 12%. These numbers have come from two studies that were both done in adult patients, in intubated patients with septic shock, both around the same time, had pretty good positive and negative predictive values, but there were also several different caveats to these. For both of these studies, the patients were intubated. They were completely synchronous with the ventilator and did not have any spontaneous breaths. They were ventilated with tidal volumes of 8 cc's per kilo. They didn't have any reasons which would falsely elevate the size of the IVC diameter. And Dr. Basu's group tried to replicate this study in pediatric patients and actually did not find the same result despite using the same or very similar careful considerations that were used in these studies, and found that the positive predictive value and negative predictive value in pediatric patients is much lower than what is quoted in these studies, and didn't find it to be a useful data point for volume assessment in pediatrics. And then the last thing that I want to talk about is the aortic blood flow variability. And the way I like to think about this is the echocardiographic equivalent of pulsus paradoxus. So in mechanically ventilated patients with volume responsiveness, with passive inspiration, there is an increased intrathoracic pressure, there is decreased venous return, and there is a change in the stroke volume, it decreases. And then as the patient takes the next breath, which is a spontaneous negative pressure breath, then the venous return increases, the patient's stroke volume increases. And so there is this change in patient's venous return and stroke volume from breath to breath, which to me is the echocardiographic equivalent of pulsus paradoxus, and which is what we're trying to measure. Let's look at how we do this, and then we'll go back to the two formulas that are used for aortic blood flow variability. So this is generally done in an apical 5-chamber view, where you're able to see the aortic outflow tract. More than any other assessments that we've so far talked about, we want to make sure that we get a reasonable to a good quality apical 5-chamber view. What does that mean? For an apical 5-chamber view, you should be ideally able to see the apex of the heart. You want to be able to see the interventricular septum in the center of the screen, and then make sure that this isn't a foreshortened view, and you're actually able to see both the ventricles, both the atria, and your aortic outflow tract. And then the pulse wave Doppler, along with Doppler gate, is placed at the entrance of the aortic outflow tract, and then you obtain the pulse wave Doppler gate. Because in this case, the probe marker is right here in the top, and the direction of blood flow is away from the probe. So we would expect to see Doppler tracing below the baseline. This is what that tracing looks like. And so right here is your baseline. And then we see different systolic peaks, and then diastolic blood flow as the blood ejects out of your aortic outflow tract. And those different values are looked at and measured. So having taken a look at that, we'll go back to our two formulas of how AFB variability is measured, and then go back to our examples and our images. So So again, if we can use either the maximum, minimum values, and the mean of the peak velocity or VTI, versus it can use the max and the min and VTI mean. And based on which formulas you use, either more than 12% or more than 18% is considered as fluid responsive. So coming back to our picture, there are two ways that we can use this image. One is when you obtain a trace of this Doppler waveform. And when you trace this out, that is what gives us VTI, or velocity time integral, where we're measuring the distance traveled by blood through the aortic outflow tract as a function of distance and time. And so you measure whatever is the largest wave, and you measure whatever is the smallest wave within a few respiratory cycles and plug that into the formula. Alternatively, if we're using just the maximum velocity, then you pick the largest and the smallest peaks and measure only that maximum point. This is sometimes helpful when anybody is starting with this, because sometimes doing a trace can be a little bit more technically challenging and can introduce error because of that. And just measuring the peak velocity can be a little bit easier to do. This is an example where the peak velocities are quite different. And so if you were to do the calculation, the variability with the peaks comes out to be more than 15 to 18%. And here's another example where the aortic blood flow variability seems to be minimum. And in this case, when we measured out the variability, it came out to be only around 10 to 12%. And so this patient was not deemed fluid responsive, while the other patient in the previous image was. This is the last slide that I have, and I want to just spend a few minutes going through the evidence for this. And so this has been evaluated in multiple studies now in pediatrics in multiple different settings. So here we see in this meta-analysis, there are from general pediatric ICU to the cardiac ICU and ORs, in both spontaneously breathing and mechanically ventilated patients, and found that aortic flow variability is a consistent and accurate predictor of patients' fluid responsiveness. And so slowly over the course of the last 2 to 3 years, we have completely transitioned to using aortic flow variability as our predictor. And so really that's all I have for the different elements that are available to us, and I'm happy to take any questions